One. So, good evening, everybody, and welcome to the first voice webinar. And to open the point on OrthoTV, it's an online platform providing free education for surgeons, started by me and my partner, Dr. Neeraj. We have a convener, Dr. Rujuta Mehta. She's a consultant pediatric orthopedic surgeon at Jaslok, Nanavati, and many other prominent hospitals in Mumbai. She is the head of department at Vijaybai Hospital, and she is listed in the top 20 women's achiever in medical field. And most importantly, she is the founder and chairperson of W.O.I.C.E, as well as founder secretary of Asia Pacific Women's Advocacy Cell. So, welcome, ma'am. And to introduce our co-convenor, Dr. Chasanal Rathod. She is working at SRCC, NH Children's Hospital, LH Hiranandani Hospital, and many other hospitals. She has been trained internationally, and she has received various awards from POSNA, from CICOT, of course from POSI, as well as from American Academy of Cerebral Palsy. So welcome, Chasanal. And to introduce voice and worthy, I'll invite our convener, Dr. Rujuta Mehta. Over to you, ma'am.
Thank you very much, Ashok and OrthoTV. I think this is a wonderful platform that we are having today. Is my screen visible now?
Yes, ma'am.
Okay. So this is a very, very special webinar that we have today, because it is being held under the aegis of IOA in collaboration with APOA and APOA Waves, which is the newly formed body for empowerment of women orthopedic surgeons and education. Voice is the collective voice of all of us orthopedic ladies in India. And just to tell you a little bit about this journey and why I thought of starting this, is that when I met Dr. P.K. MullaFeroze in 2005, I was literally amazed and absolutely in awe of her personality. She was such a simple human being. Today is her birth anniversary. She was the founder, president of the Indian Academy of Cerebral Palsy. She was the stalwart and legend in Children's Orthopaedic Hospital, Haji Ali, which catered to the care of the sick children and especially disability for many, many years. And when I met her, she was 6 feet towering and a very awesome woman at 92, also still standing straight, absolutely lucid and clear. And if she come orthopedics more than 36 years back, and there were several other ladies who have been there, but they were never collectively put together. So I was inspired under the able leadership of one of our speakers today, Dr. Ram Prabhoo, who was the organizing secretary of Golden Jubilee IOCON 2005 in Mumbai, and where we had a small session and just a few of us, you can see how many of us are gathered. Then we all realized that most of us have been recipients of this Marcella Uribe Zamudi Award, which is a triennial award given by CICOT. And I felt that there is nothing really in India which promotes and encourages an education of ladies in orthopedics. And they really do need that push because they are swimming against the current. So in 2017, again, under Dr. Ram Prabhoo's leadership, when he was the IOA president, we formed the functioning of the ladies cell, and Dr. Mandeep Dhillon actually then took it forward in his presidency. So these are the functions that we do. I think our main focus is a lot on the health of the women and the girl child by view of community awareness drives. We have almost 290 ladies all across India, which is a huge, huge number for the rest of the world when we see that there are some countries which have only 4 or 5 ladies in orthopedics, and yet they have come together to form their own society. We were very sure that we wanted to be part of the IOA because IOA is an excellent national platform to launch a lot of initiatives. There are CMEs which we conduct. We have a counseling cell for all the ladies who have some issues when they get into a different branch and they need a lot of boosting up all along. We have Yuva scholarships now for them to take up, mentorships, whichever way they want. And we have a dedicated session 1 hour in every IOCON. Plus, we have a best paper prize in late Madam P.K. MullaFeroze's honor. So I think voice has come a long way. And these are just some of the activities we've done over the years. In 2018, Chasanal and myself, we did it, one in HN, one in Nanavati for osteoporosis awareness for general practitioners. And in 1920, again, we had something on the International Women's Day, where we had 3 lead speakers across the world. In 2019 in Kolkata, we had a huge session where some of these girls, you can see, presented free papers. And one of them actually won the award. And we had the elite guest, Dr. Christy Weber, as the main chief guest of the entire IOCON. So the award was given by her. And 2 of our stalwarts, Dr. Vrisha Madhuri and Dr. Shobha Arora, who will be speaking in the subsequent sessions also later. 2018 also we had one session in Coimbatore, but I've not been able to put up the details here. Then we did mother and child health activities in 2019. In Bombay Orthopaedic Society, we had the first of its kind presidential symposium, where we did a Get It Right the first time, presented totally by all the ladies. And this is Dr. Sunil Shahane, our president at that point. And subsequently, the baton has been taken up in Nashik and many other places. And this year, we've had a very vibrant virtual meetings all along, again on International Women's Day, hosted by Ratna. And training of the trainers, as you can see over here, for all the younger postgraduates, ladies, which went excellently. And myself and Binoti were invited to the CSRC, that is the Central Asia Regional Conference, with the Association of Women in Medicine in India. And I think they're trying to spread the awareness. And with WAVES, that is the council members, each of them who will be chairing the respective sessions. This webinar series will be held every Sunday. Chasanal will tell you more details. And we have a very exciting tie-up with WOW, which is Women Orthopods Worldwide, coming up in future. So with this very brief introduction, I think I'll hand over the mic to Chasanal.
So thank you, ma'am. And that was very nice, like the way you have showed how voice has come all the way. And I'm glad to be part of it with you throughout this and throughout the, So all this time we had been planning to work on a webinar or a series where we could highlight more of work being done by the female orthopods. And ma'am and me, we just discussed a couple of ideas and had brainstorming over this. And we came up with this idea to have a tribute for late Dr. P.K. MullaFeroze, the first lady orthopedician from India. And we started this, we decided to have this worthy webinars. That is what makes this talk the most worthwhile or worth of what's your worth kind of thing. And with this, from today onwards, for the next 5 Sundays of the month of October, we shall be hosting this webinar series every Sunday, 4 to 5 p.m. on OrthoTV online. And we have a variety of speakers and a wonderful program which has been set over for the next 5 weekends. And I'm sure that people who have joined us today are looking forward to more of these over the month as well. And to begin with, we have the first episode today, and we have our guest speakers, Dr. Poornima Patni ma'am and Dr. Ram Prabhoo sir. And to chair these sessions, we have Dr. T. Sara from Malaysia and Dr. Rajesh Gandhi sir from Mumbai. So I'll quickly introduce you to our chairpersons for the day today. And we have I request Rujuta ma'am to kindly introduce the chairperson.
So my pleasure, absolute pleasure to have Dr. T. Sara as the nodal chairperson of the very first inaugural webinar today. Everybody on this panel, in fact, has their heart really woven into hand surgery. And who better than T. Sara, who is a very, very well trained and veteran hand and orthopedic surgeon from Malaysia. She's been a full professor up to 2020. And although she's retired, I assure you she's full of energy and she's still very, very active in teaching everywhere. She's a visiting specialist with the University of Malaya Medical Center and the president of the Malaysian Society for Surgery of the Hand and Malaysian Orthopaedic Association. A very gentle and a very warm leader who has supported a lot of the girls in APOA in fellowships, as I have heard from personal communication with one of my close friends in APOA. So lovely to have you, Sara. And she's part of our council of the WAVES, which is Women of Orthopedic APOA, who will educate, advocate, and empower and support. So that is what WAVES is all about. And we have our other chairperson, who is, I think both the chairpersons share a very, very simple and similar outlook towards life, that they are very, very warm and congenial. One of the most loved orthopedic surgeons in the entire Bombay Orthopaedic Society, a very humble man and a total people's man, Dr. Rajesh Gandhi, who is our president-elect of the Bombay Orthopaedic Society, who takes over in 2022. He is a hugely successful private practitioner, as you can see in many of the hospitals here. He organized one of the best WOI.C.E, which is the pride of Bombay Orthopaedic Society, in 2012, and also was the joint organizing secretary of the APOA conference in 2015. He's had a long legacy of serving the BOS. And besides this, he's had a huge association with Dr. B.B. Joshi and with JESS and with a lot of hand surgery. And he and I share a PG teacher also, Dr. Tarapurwala. So without much further ado, I welcome the chairpersons and request them to take over the proceedings. Chasanal will be introducing both the speakers, and then we can begin with the talks.
So thank you, ma'am. And our first speaker for this webinar is Dr. Poornima Patni, ma'am. And like Dr. Rujuta ma'am mentioned, that it's an honor to have you, ma'am, for this first episode of Worthy Webinar. And ma'am is a hand surgeon based in Jaipur in India. She was affiliated with SMS Jaipur Hospital, where she retired as head of department and additional principal for the SMS Medical College and the group of institutes. And currently she's at Apollo Spectra Hospital, where she's director and head of the hand surgery department. Ma'am has been had a vast experience of around 40 years in this field, and she has been working in this hospital with around 14 years of her career, and she has been mentored to like around 25 PG students, and their thesis work and research work has been done under her guidance. She has many national as well as international publications. She's the founder president of Jaipur Hand Surgery Association. And for the upcoming ISHCON in 2022, she's the organizing chairperson. So we welcome you, ma'am, and thank you for joining us all the way from Netherlands. It's a pleasure to have you, ma'am. Thank you so much. And over to you, ma'am.
Okay, can you see my screen now?
Yes, ma'am, it's visible.
So, hello everyone, and thank you Rujuta and Chasanal for giving me the honor to share my story on this very special day. Before I do, let us start out today by admitting that we are lucky. We don't live in a world, sorry, just a second. We don't live in a world our mothers lived in, our grandmothers lived in, where career choices in medicine were very limited for women. When I started in orthopedics in 1976, I must admit I was hesitant. I was hesitant for one thing. I wasn't sure if I was physically strong enough for orthopedics. Of course, I learned quickly, and I don't need to tell any of you successful women orthopedicians that orthopedic surgery is about technique, not strength. As one of my first teachers taught me, if you're using too much strength, you're doing it wrong. But there was another reason. I was apprehensive when I started. Unfortunately, back then, you didn't see many female orthopedicians. There were no peers around, let alone women leaders to look up to or learn from. In fact, For a long time in the beginning, I felt self-conscious, like I was being watched. Will she stick to it, or will she quit and find her happily ever after domestic life? Well, 45 years later, I'd say I stuck to it and I found my happily ever after. But it wasn't easy. It's never easy. We all know that women have to work harder for the same job. Even the lucky ones amongst us with wonderfully understanding and supportive families do have a job at home besides our job at the hospital. But I'm not here to talk about that. My talk today is about the light at the end of the tunnel, about how much sweeter the reward is when you feel you worked your hardest. So back in 1976, I was fortunate enough to have had the legendary Dr. P.K. Sethi, the man behind the Jaipur foot, as my teacher. Or should I say guru? Early teachers really had such an influence over who you turn out to be. Dr. Sethi never gave us answers. He kindled our interest and encouraged us to think for ourselves, to focus on reasoning and analysis. It was also thanks to him that I developed an interest in rehabilitation medicine as well. It was really the most wonderful teaching experience, learning experience. Only a couple of years after I had completed my MS and started as an assistant professor at SMS Hospital, I was posted in the hand surgery unit. Back then, our hospital boasted of having one of the few hand surgery units in the country. But I'll be honest with you, I wasn't too thrilled about the posting. Hand surgery wasn't glamorous. It was just day after day and night after night of tedious industrial and agricultural accidents. Night emergencies were a challenge. The fact is, the fate of the patient is really sealed in the ER. So much as I hated leaving sleeping babies behind, cases like this needed to be operated there and then. In this case, for example, we sacrificed the unsalvageable index and middle fingers, filletized the fingers, and used them to cover that, and the remaining area was covered with a huge abdominal flap. All this in the ER at 2 a.m. It was timely coverage that led to good recovery. We were able to save this mangled hand, and as you can see the image on the right, our patient finally had a functional limb. Sterling Bunnell had once said, when you have nothing, a little is a lot. This is a perfect illustration of Sterling Bunnell's statement. This patient came to us with a stump of the first metacarpal and the remaining ring and little fingers and a tightly closed wound. A one-stage reconstruction was done by translocating the ring finger to the first metacarpal base, and a groin flap cover was done, again in the ER, thus giving him function in the little that was left. So what started with all these hardships that you are all familiar with in your own experience turned out to be a success story at the end. Hand surgery is no longer an unglamorous assignment. During the course of my career, I was able to generate interest in the subject through teaching and numerous publications. And I'm proud to say that through my work, what I consider my major success is, much like my own teacher, I was able to spark interest in my students towards the subject. And today, many of them have taken hand surgery to much greater heights. In fact, for more than 2 decades now, we have been running what we call the Wednesday Hand Clinic, or the W.O.I.C.E. It comprises of a group of hand surgeons and therapists, like-minded people who run this clinic every week, free of cost. We discuss complicated cases and related issues with the objective of learning from each other. More recently, we have formalized this group into the Jaipur Hand Surgery Association, and next year, we will be organizing the National Conference of ISHCON 2022 at Jaipur. So if nothing else, I'd like for you to have just one takeaway from my journey. Don't quit. Stick to the fight when you're hardest hit. It's when things go wrong that you must not quit. Now, I've been asked to highlight some of my best work. I would like to say my favorite work. I shall be talking about giant cell tumors of the lower end of the ulna. This was a 25-year-old female who was operated elsewhere by a curettage and bone grafting, came to us 1 year later with an aggressive lesion. Now, this meta-analysis on which is the best treatment for giant cell tumors tells you that the intralesional excision did not provide the same local control as en-bloc resection, and recurrence rates remained as high as 31% despite various adjuvants being used. For the Campanacci grade 3 giant cell tumors, the possibility of recurrence for intralesional excision group was nearly 5-fold greater than those for en-bloc resections. Giant cell tumors metastasize in the lungs. The distal radius is the third or fourth commonest site with approximate incidence of 13%. Giant cell tumors are always malignant, though late to metastasize and have a propensity to recurrence. The management, as in all other cases, is to cure the disease and preservation of maximum function. We have been using the procedure described by Houchang Serge in 1982. He does a radical excision of the lower end of the radius with the tumor and translocates the ulna. The articular surface of the ulna is denuded. It is shifted along with its soft tissues, attachments to a notch created in the proximal surface. The ulna is translocated along with its soft tissues and fixed with an intramedullary K-wire. This is the procedure that we have been following now for many years. This was how we go about it. You can see the result. We have finally been able to bring out a publication in the year 2018. Now, our study is a retrospective study of 20 patients. All the cases were operated between the year 1996 and 2011. I must add here that over the last 10 years, we have another collection coming up, but we have not been able to publish it so far. The average age was 33.15 years, and grade 3 tumors were 14 in number, and grade 2 tumors were 6 in number in our study. The diagnosis was confirmed by biopsy. There were 6 cases of recurrence. The extent of the tumor. In our earlier cases, where the facilities were not available, we used to judge the level of the excision from the radiological appearance. We would take a clear margin of 2.5 centimeters proximal to the radiological appearance of the tumor. But now we have CTs and MRIs to guide us. Metastases were ruled out, and a complete neurovascular assessment was done preoperatively. A large curvilinear dorsal incision is used to access the tumor. It is curved a little ulnawards, you can see, so that you can access both the bones. Sometimes a volar incision may be required in 2 instances where either the case has already come handled elsewhere and is showing a recurrence, or if the tumor is excessively large and you might need to supplement on the volar side or maybe just go on the volar side depending on the presentation of the tumor. Now the ulna is translocated. Sorry, this is the ulna. This is the distal end of the radius. Now the ulna has been, you can see over here, there is a slot in the carpus. This is the slot. This is the distal end of the ulna. It has been translocated in total. And this is the proximal end of the radius. Line diagram will explain this better. You can see this now. In our earlier cases, we used to struggle a lot with a step cut osteotomy, with the assumption that a larger area of contact would be better for union. But the process was a little difficult. There was more in stripping of periosteum involved, and the procedure became very tedious. And by the time we really translocated the ulna to the cut end of the radius, there was invariably a little bit of a rotation, and fitting this step became impossible. So in this case, we were lucky that it united. So we have since then modified our procedure. We do a sharp transverse osteotomy, a clean cut circumferential division of the periosteum. The periosteum is stripped from the proximal part of the cut end of the ulna, of the proposed site. And the ulna is shifted to the radius. Now we have started using a very snug fitting translocation. The ulna is cut just a tad bit longer than the actual gap from the carpus to the cut end of the radius. Initially, it's a little alarming to see. If it's very tight fit, that you can see that the intramedullary wire is bent and there's a little bit of an angulation. But as time goes by, there's a little resorption of bone at the distal end, at the wrist, and at the proximal end, and eventually the bone straightens out. In our earlier cases, we also struggled a lot with getting a intramedullary fixation through the third metacarpal. And we have since then abandoned this, and we settle with any snug wire, which may, like in this case, for instance, you'll see that it is skirting the fourth metacarpal, but it was a good stable hold, and an additional oblique K wire to prevent rotation is used. Also, what we found was that there was a good mid-carpal joint line, which was preserved. So what we have started now is we do not denude the articular cartilage from this part of the ulna. This is raw, so that it unites with the scaphoid, and some jog of mid-carpal movement is maintained. So what in our earlier cases, we would excise the radial extensors since they were of no use. But now we have started preserving at least one radial extensor, and we have found that 10 to 15 degrees of movement are possible. It's like a proximal row carpectomy, you know. So we have started doing that. Some adjuvant reconstructive procedures came our way. The median nerve was showed an hourglass constriction through chronic pressure, and we had to do an external neurolysis in one case. The extensor pollicis longus tendon invariably was in very close proximity of the tumor, and because and had to be sacrificed in 5 cases, we were able to do a transfer with the humerus longus to regain the function in the same sitting. Groin flap cover was required in 2 cases. These were huge tumors. You can see they have infiltrated the skin and soft tissues. Another interesting thing that we have found over the years, now this looks like a hopeless situation. The tumor has blown out into the soft tissues. But when you operate on the table, you will find that the tumor is contained in a reasonably good soft tissue envelope. And we have taken care not to injure this soft tissue envelope. With liberal soft tissue excision, we have been able to get away with a number of such cases. Large excision, and the raw area was covered with a groin flap. Now, of course, the extensor of the thumb was sacrificed in this case, and it was transferred with the palmaris longus. You can see the K-wire in the thumb, which was used to support the transferred tendon when the groin flap was applied. The post-operative protocol is simple. Long arm cast is used for 3 months, and then subsequently a functional cast brace for the next 4 weeks. Of course, subject to the radiological appearance. The average follow-up was 3.9 years. The proximal end of the translocated bone was a little troublesome. Radiological union was seen in 4.25 months. The average duration of immobilization was 4 months. What was interesting and worth showing here is that we had almost a full range of pronation and supination. And this cannot be achieved in any other procedure described. And cosmetically, all patients graded these as good results. Non-unions occurred in 6 cases, all at the proximal site. There was no difficulty in union at the carpal level. Cross union in 1 case. I think there was a tag of periosteum which was responsible. We excised it and were able to regain. Superficial infection in 2 cases, handled promptly by incision and drainage and antibiotic coverage. There was a large hematoma in 1 case which settled after drainage, and a split skin cover was used later on. Recurrence of tumor in 2 cases. 1, it was a local, and in 1, there was a pulmonary metastasis. This was a 35-year-old woman showing excellent results, but came back 2 years later with the local recurrence and a huge pulmonary metastasis. A lobectomy was also done, but we lost this patient. Recurrence in a fibular graft. You can see, again, we did a huge excision, covered the raw area with the groin flap. In this case, we had a problem at the and union at the proximal site, and we used a plate and bone grafting. Went on to unite, but she came back 10 years later. She came back 10 years later with the recurrence. Sorry. She came back with the recurrence at this place. So, and also strangely, there was a strange looking appearance here also. To conclude, I'll say that largely 3 procedures have been advocated for the tumors of giant cell lower end radius. Fibular graft reconstruction, very exotic procedure. A lot of vascularized fibular grafts are being used. Requires a prolonged immobilization, and the wrist is never normal in these cases. However charming the X-ray looks, the wrist never regains a normal function. There is always a problem at the distal radioulnar joint. And of course, there is a donor site morbidity. Centralization of the ulna is a simple procedure. It is cost effective, less demanding, but it is very poor cosmetically, poor function with the wrist fixed, no pronation and supination, and an altered muscle pull. So we have continued to use our procedure. This is an X-ray. It's a poor X-ray, but it shows you how bad the wrist is after a fibular graft. This is another point I wanted to highlight. Often a patient comes to you after having had a biopsy elsewhere, and this is an incision. This is the scar of the biopsy at the mid-lateral line. Now it becomes exceedingly difficult to plan a definitive surgery. Your skin incision has to be incorporating this part. So my message is that, when you are planning a biopsy, please keep the subsequent surgery in mind and plan your incision accordingly. And anyway, we got away with it. This is the case. It went on to unite. This was the patient. You can see the wrist is looking a little constricted in this case. Partly also because of excessive skin resection that we had to do. We didn't like the appearance of this wrist, but the patient was very, very happy, and she said she would conceal it with more bangles. So this was her function. So translocation of a vascularized ulna is our preferred method of treatment. It is technically less demanding. It's a single stage procedure, no donor site morbidity. Strangely, there are no complaints at the proximal end of the ulna. You would think that we have cut the ulna so high up that the patient will have some problem. There were no problems at all reported by not even one patient. It provides a stable, painless wrist. It's cosmetically acceptable, and an early rehabilitation is possible. So I would like to conclude that giant cell tumors are not benign. And if one has to balance between a complete cure of the disease versus preservation of wrist function, I think the balance tips in favor of curative treatment, which would mean an en bloc resection and a wrist arthrodesis or whatever. Thank you.
Yeah, it was a wow presentation, if I have to say.
Yeah.
Very good presentation.
Thank
I
you.
have few points to discuss with you.
Yes.
So first and foremost, ma'am, when you see such a large lesion, what is the role of denosumab pre-operatively? Because some studies have shown that they shrink the size of the tumor and then take up the procedure to do the resection.
Yeah, we have now started using it. You'll see that my study is limited from the year 1996 to 2011. Subsequently, we have now started using it.
Okay. How often do you give in that case?
Well, it's one of those, like this case with the recurrence you saw after 10 years. We sent her off to, I didn't show you the follow-up of that case. We sent her to the oncologist for further management. But I personally have not used it in any of my cases so far.
And wide resection is with the soft tissue all the time, or when there is a breach in the cortical continuity?
Yeah.
You advocate wide resection in each and every case, or where there is only cortical disruptions?
You saw a few cases. I showed you what looked like a hopeless situation. But we went ahead and did a wide margin. And we have always been taking a biopsy of the cut end of the bone also to see the presence of tumor tissue. And in fact, earlier we would limit our excision to about 2.5 centimeters proximal to the radiological appearance. But in situations like this, we have gone ahead and taken even larger gaps. And since it was a vascularized fibula, ulna, there was really no trouble which we had. What would you advise in a case which is blown out like this?
Oh yeah, wide resection is obviously indicated.
Would you sacrifice the limb?
Preferably not. Limb-saving surgeries are always heartening and designed.
Sorry.
Sorry, we lost you. Yeah, I'm sorry, we lost you.
Yeah.
We would not sacrifice the limb. We would try to preserve and get maximum function. I think it's a wonderful method we have described, wherein centralization of the ulna is done after the wide resection. Did you face any long-term problems of ulnar fractures following centralization?
No, we have really taken our time in removing that intramedullary K-wire when we were absolutely sure that there was a good consolidation. And most of the times, actually, if the K-wire is placed properly and it's not bothering the joint movement of the metacarpophalangeal movement, it can be left inside also. So fortunately, we have not encountered that problem.
Oh, yeah.
Non-union, I think we had 6 cases, I think, if I remember correctly. But they united very readily with the plating and bone grafting.
Any questions from Dr. Sara?
No, I would like to congratulate Dr. Poornima. Very nice series. I like your journey to begin with. I was going to ask about denosumab as well, and the proximal ulnar stump, whether it were bothered, but you already answered that before I could ask. And I have done free vascularized fibular graft for this problem, but I would say, yeah, the wrist is never normal. And in this way, I think you have settled the thing, you have settled the problem almost for once and for all. And I like the way that you, being very familiar with the reconstruction, doing it so much, you have now modified it to give a jog of mid-carpal movement. I thought that was very nice. And yeah, a lot of these almost unsalvageable situations have been salvaged by this reconstruction. So I will congratulate you. Thank you.
Thank you. Thank you.
So, Dr. Poornima Patni, it is excellent paper and it's a wonderful way of managing this. Of course, many of us here in Mumbai have been doing the opposite fibula, upper end of the fibula transfer in such cases. But I think even this is a good method. Only I would probably suggest, or maybe because you had 6 non-union cases, maybe in these cases, or otherwise, primarily plating of the proximal end and K-wiring or nailing of the distal part may be a good idea, rather than having one wire which goes through and through. Because
yeah, but that would require a lot of soft tissue stripping.
Possibly, yes.
The whole idea is to have a vascular. So if you use a plate, you will be stripping the soft tissue.
Yeah, that's right. Perfect. I mean, but
So,
it is excellent.
I mean, why do a primary thing if you can get away with just you use a stout 2 mm, 2.5 mm K wire and an additional wire to prevent a rotary
instability. Yeah.
Movement.
That's right.
So I showed you in some of my slides that an additional oblique K wire through the carpus. Yeah. And we have got away with that. Maybe in a couple of years, one of my students will come up with the remaining cases that we have for you.
No, but excellent. I'm really hats off to the result that you have shown. And this is relatively problematic cases that you have shown in this. And of course, in Mumbai, we do not get so many GCTs as compared to some other parts in the other states. Maybe in Rajasthan and even in eastern part, in Orissa, etc., we see lots of GCTs in different parts, So, but I really congratulate you for wonderful presentation, first of all, and excellent cases that you have shown.
And we have 2 questions more for Poornima, ma'am.
Yes.
Ma'am, what is the indication of proximal carpectomy in distal end GCT?
No. Proximal carpectomy was not done.
Not.
We just removed the lunate and we made a knot for the...
Okay. And ma'am,
it was just...
and the preferred procedure, translocation or centralization, and the pros and cons of it, ma'am, is the next question.
I've already shown you in my slides. The centralization of the ulna is a simple procedure, and but the results, because of an altered muscle pull, and you are not able to get any pronation and supination. Can you imagine a wrist with no pronation, supination, and a stiff wrist? It's much more disabling, and an altered muscle pull, and cosmetically not so good looking. So a translocation of the ulna, except in some cases where, it's a little thinner around the wrist. The forearm is a little thinner around the wrist. But most patients don't come back for any procedure. There have been procedures described where you would do a filler sort of a situation, but nobody comes back for it, at least in our series. And it's interesting to know from Ram Prabhoo, I didn't know there was a geographical variation in the incidence of GCTs. So
probably something to do with the number of territories or districts that I think Savai Madhopur hospital drains. And
Savai Mansingh.
That is possible, but I had an opportunity to go to Cuttack, medical college as a traveling fellow in 1986, and I was amazed to see the number of GCTs in various different parts, the lower end of the femur, the upper end of the femur, upper end of the tibia, lower end of the radius. At one time, there used to be 8 to 10 patients operated in the ward.
Oh my.
And it was amazing. And they had one of the largest series of, those Maldiabun surgeries that they used to be done that time, and even the tubular transfer, etc. And I was amazed to see that. There are a couple of other endemic things that we saw was contractures, deltoid contractures, quadriceps contractures, which were very, very common there in Orissa, which is not so much at all seen here in Mumbai. So similar, so probably it is possible that in Rajasthan and some of the western coasts it's maybe prevalent.
Possible.
Or maybe because the drainage that we see.
Yeah.
So thank you very, very much, Patni madam. I think it was very enlightening, both your journey and the long-term experience that you have shared. And I'm sure all our audience has been enriched, and many more of our audience will be encouraged to take up this very practical and durable procedure that you have shared with us today. So Chasanal, shall we move on to our next illustrious speaker, Ram Prabhoo sir?
So thank you, Patni ma'am, and we welcome you, Ram Prabhoo sir, and thank you for being with us for this webinar. And also, like ma'am mentioned, thank you for being the inspiration to start WO.I.C.E and supporting us, sir. Thank you so much. So we have Dr. Ram Prabhoo sir with us, and sir is a very well-known ortho surgeon in Mumbai, India, and he's known all across he's globally known, and sir has been past president of BOS twice, that is the Bombay Orthopaedic Society. He has been past president of Indian Orthopaedic Association as well. He has been past senior VP of APOA. He has conducted more than 300 workshops and taught more than 6,000 orthos globally. And he has many applauds to him, like 17 orations. He has been an international guest lecturer across many conferences. And the last Golden Jubilee IOA Con, that is the Indian Ortho Association Conference, was organized by Sir. And apart from this, he has also been organizing for 4 international and 10 national conferences. Apart from his academic accolades, he has special interests in music and adventure sports. He is an avid trekker and he has gone to Himalayas and Alps several times. That is almost 31 times. So it's a pleasure to have you for our first worthy webinar episode. And I request you to take over, sir. Thank you, sir.
Yeah. Thank you very much, Dr. Chasanal, for your introduction, nice introduction. And I'm really overwhelmed by your worthy seminar that you are conducting. Thank you very much, Dr. Rajesh Gandhi and Rujuta ma'am, all my favorites for so many years. And I must confess that though the WOW has been initiated into IOA thanks to my little efforts, but it has been really a great journey for all of you. And I was really amazed in the matter of 4 or 5 years. You have done a great deal of progress, not only nationally, but internationally. I do not have any slides to share for my worthy, for my the journey of orthopedics, like Dr. Patni, who has had excellent presentation just before me. So it is very difficult to follow that presentation with a similar kind of benchmark that she has got it. But let me share a few things that just like Madam Patni, I had Dr. Rajesh. I will share this little later.
Okay.
So just like Madam Patni, I started my orthopedic career in 1977 when I joined MS Orthopaedics in KEM Hospital and JESS Medical College. And I was, of course, working very hard that any other residents do across. And there we had really little time to spend for any specialty, or there was no subspecialty that we thought of that time. But I must tell you that it was 1977, which was a landmark year for myself, which really changed my life. First thing is that I got married in 1977. And the second thing was Joshi's contact. And I did my first hand surgery course in 1979. So I must confess and tell you that I had these 2 gurus in my life who entered and changed my whole career graph. So after doing that course, I was really fascinated by the intelligence and brilliance of Professor Joshi and the way innovative things that he was thinking of even that time. And mind you, it was 7 days hand surgery course, which would start at 8 o'clock in the morning and would end perhaps at 11 to 12 o'clock. And this gentleman, Professor Joshi, would continuously take this. So it was like 12 hours to 14 hours every day, spending with us about 7 to 10 students. And that was really something great. I said that this gentleman, who was even that time senior citizen, but at that time he would spend so much time in educating, teaching, and that one single-mindedly he had this mission of Vidyadan, and that really fascinated me. And I thought that this is something that I must emulate, I must try to do in future also. After finishing my MS Orthopaedics in 1981, I said that, okay, hand surgery was my special interest, but I thought that I must know a lot of other things about orthopedics too. And that's the reason why I went abroad, did joint replacement fellowships, I did trauma fellowships, I did spine fellowships. I learned a lot in UK and in Germany. And I came back. After coming back, I realized that there is trauma which is absolutely needed. And I got a chance in a municipal hospital, which was a semi-government hospital, and a very important drainage area in Mumbai, where I became head of the department quite early in my life. So there was no option, but also to do so many different surgeries besides hand surgery. And I enjoyed doing that. And I really are thankful to the municipal and the government setup that I could get so many different cases to learn and also to publish in various different ways. I had an opportunity also to work with Professor Gastillo. And that, when I realized that in 1981, when he became a head of the department of Minneapolis Hospital, the first thing that he did was he had the importance, he knew the importance of documentation and presentation. And he computerized the whole department. That gave him ample chance to document so many different, so many thousands of cases. And that was the reason why he could actually come out with that landmark Gastillo Anderson, the gradation, the types, the classification. And that is what I really imbibed in me. I said that documentation is very important. We did not have mobiles, cameras so well. We did only have transparencies at our disposal, and the documentation was, as you know, very poor. But then I made special efforts, taught my juniors, fellows to do the documentation wherever possible. And even in the government setup, it was possible to document. You saw wonderful slides of Professor Patni today, which really makes an impact when you make a presentation. If it is very good slide, it makes an impact to everybody that how you have to go and document. And this documentation really comes handy, especially after 4 years, 5 years, 10 years, when you really get the follow-up results. And this is very important, and that importance I realized from Professor Gastillo. Other thing that I must tell that in my journey, I realized that teaching is very important, because when you are teaching, you also learn. And for that teaching, because the students are very smart nowadays, they have lots of knowledge and they keep on asking questions. So you must have those answers ready. And for that, you need to keep on updating and upgrading your knowledge. And that really gave me a lot of stimulus to read and motivated me to interact with lots of students. And that's why I proudly can say that I have almost 4,000 or 5,000 students across the world who actually keep on asking me questions still now and stimulate my brain. So friends, it is important in the journey that you must learn while you are practicing. You must also teach while you are practicing. So teaching and learning goes side by side. And this is what, again, I have learned from my international friends, that teaching is a great food for thought, and you must keep on doing this to your younger people. Another advantage is that when you are with younger people, your thoughts are young, you start looking young. And that's what I saw in Madam Patni today, that the first encounter that we had, Professor Joshi and myself, and she would perhaps remember when Professor P.K. Sethi was there, we went almost 25 years ago to Jaipur, and we were pleasantly surprised to see amount of work that was being done in their medical college. And I must also tell you a small secret, that Professor Patni was, Madam Patni was B.B. Joshi's favorite. She may not know that, but Professor,
I wish you had told me earlier.
in his mind and this thing, he would remember her so much, and she was his favorite. And the reason for this is obviously her work, and probably she would always look young, because Professor Joshi had an eye for young ladies. Okay. So this is again something. This is one of the characteristic of him, and he would love talking about them. So, Madam Patni, we have those memories. Thank you very much for keeping those memories alive. So we saw lots of work across India and internationally, going to different medical colleges. And I must say that in India, there are rural medical colleges, there are places in tier 3 cities where there is a phenomenal work being done with whatever facilities that they have. And that is what again admires me, that these people have their own modification, even if they don't have technologically very high-end hospital, the operation theaters or the equipment, they really do a great job. As I was mentioning before, in Cuttack, I saw this giant cell being operated, and I saw some of the theaters, operation theaters, did not have proper cautery, didn't have proper suction. These patients had hemoglobin of 7, 8, 9, and they would do these surgeries, in those places. And in fact, that gave me a lot of confidence that even with these circumstances, people can operate at these places. Why can't we do the similar kind of high-end work in Mumbai, where we have excellent infrastructure? In fact, after coming from Europe, I was slightly disappointed that we can't replicate the similar kind of results here. But after having gone to Ranchi, Cuttack, and such places, I realized that it is the man behind these machines, man behind this equipment, which is very important. And you can really do some miracles with whatever facilities that you have. And we have such wonderful teachers all across India, and they have a potential to teach anybody and everybody with whatever small equipment, even non-mechanical handmade instruments also. And they have modified those instruments to fit to have a similar kind of result. So thank you, madam. With just simple KOR, if you can manage this, really you have done a great job. I must congratulate you. So after having said that, my journey still continues. I continue to do my orthopedics practice, as well as I continue to teach. I still continue to have workshops and interact with my students all across. And that is how my journey continues. And thank you very much. I had an opportunity. My friends also helped us in our the whole journey. I must tell you a couple of names like Professor Ashok Johari, Anand Joshi, who have been my colleagues, and they have been instrumental in pushing each other whenever there are some crises, whenever there is a little bit of dip in our moods. And they have been really instrumental in pushing us, stimulating us always. So that also, as friends and colleagues, it is very important that you must support your colleagues and push them if there are, because in our life, there are not that all the patients are successful. There are sometimes some problems, complications, and that those times we are slightly low. And that is a time when we really require our colleagues and friends. And you must help your colleagues whenever there are certain problems like this. So thank you very much for allowing me to talk, Dr. Rujuta and Chasanal. Now I can share the screen and talk about the topic. In fact, it is not particularly hand, it's the upper limb. And I'm going to talk about JESS in the upper end of the humerus, which again is a brainchild of Professor Joshi. And I'm going to talk about it today. I hope that the videos also work. So we know that there are various different types of proximal humeral fractures. There are various classification and gradations which are there. But in short, just to make it a little simple, we have either stable proximal humeral fracture or unstable humeral fracture. And to just for this presentation, I am going to talk about NITS terminology, which separates this fracture into 2, 3, or 4-part fracture. And the treatment more or less is the same what we have decided. So in these particular things, when we are using JESS, we have selected these patients, those which are unstable proximal humerus fracture with displacement. And that displacement has to be more than 1 centimeter or at least 1 centimeter. The displacement has to be either in angulatory or rotatory proximal fragment more than 45 degrees, or it has to be irreducible, or if there is a loss of reduction after closed reduction. And then, of course, there are 2, 3, 4 part of proximal humeral fracture, which are unstable. And finally, a compound fracture, which is very important for external stabilization. So now we have so many different methods of working, and we have open reduction, we have Philos plate, we have nails, and so many things. So what is the need for finding out a new method or a search for a new method when there are already established that there were excellent to satisfactory cases of 50 to 60%. That was a big amount, and which was good and which was also encouraging. But at the same time, you must realize that that also means that 40 to 50% of the patients were not really happy. So why is it that? So therefore, there has to be a method which is needed, which has to be technically less demanding and less invasive, leading to a stable fixation of the good results. And why we have to use JESS? Because it is less demanding, it is relatively cost effective, and at the same time, a relatively younger junior orthopedic surgeon also can do this method, and that's the reason why JESS has been chosen over many other methods that we have. But at the same time, this method also, like any other system, has some limitations. And what are those limitations? We have excluded cases like split, vertical split or horizontal split of the head of the humerus. Of course, the impacted and undisplaced fractures were never done operatively. They could be conservatively treated also. And fracture dislocations, which were unreducible by closed methods. Though we did some cases, about few of them, less than 10 cases, we have also tried in dislocated, where we could actually joystick that fragment and get it into alignment. But we don't really recommend that case to be managed by JESS, especially those who are initiated for the JESS in the beginning. And those cases which are presented after 3 weeks, it is not possible to do those cases after 3 weeks. It becomes very difficult. Even open reductions are difficult. So, can we skip this video, please? If it is not, is it working? So I will just show you a case where this was a 4-part fracture in an osteoporotic bone, which becomes probably mandatory to operate such cases. All of us would probably try to do a Philos plate. Some of us would do some kind of nailing, which are there available nowadays. But of course, this is a challenging case. For all those orthopedic surgeons, even the traumatologists who manage this, and we cannot really 100% give guarantee of excellent result at the end of the operative procedure. So what we did was passing 3 K wires, and mind you, all these K wires are not threaded. There are smooth K wires which are 2 to 2.5 millimeter in diameter. What we do is abduct this arm so that the greater tuberosity comes as close to the humeral head as possible. Pass these 3 K wires in a different direction, so that they have a proper global contact. This is the way we do it, so that we have them in a different plane holding the head. Of course, we need to check that in the C-arm. Then, after having done that, we pass 3 K wires or 2 K wires, similarly 2 to 2.5 millimeter in diameter. They are also smooth in the shaft, distal shaft, and this is how it is kept. After having done that, we have a hold on the upper and the lower 3 K wires so that we can actually reduce that. But you have to check that reduction under C-arm, AP, and also axillary view. And after having done that, we put the link joints through and arc in the upper construct so that we tighten those, giving a good hold. And similarly, we have a 3 link joint which is holding the lower 3 K wires. And what we do is we pass a connecting rod holding the upper arc to the lower arc. And this is how it is done. When we are tightening the lower screws, we have to see the reduction again so that it is proper. Because what happens is the lower fragment gets distally or it gets sagged. So that is what we have to prevent. And this is how the final construct looks like. And let me have the X-ray if possible. So if we can show the movement, and this is how this is, just go slow, please. So I will show you the X-ray. In this, you can see the alignment is pretty good, though it is just 3 K wires at the top and 3 K wires on the lowermost. And unfortunately, this video is not working, but otherwise I would have shown you the stability under the C-arm photograph. And this is how the whole construct looks like. And after the construct, we actually start mobilization maybe after on the 2nd or the 3rd day. These are only the pin track that we show. The smooth K wires prevent any loosening later on, and also chances of infection are very low because smooth. We used to use threaded K wires before, but those threaded K wires had more chances of loosening and infection. That is why we have given up using threaded K wires. Next. And these pendulum exercises are started immediately on the next day so that the mobilization is started. This is an interesting case of a dancer who had this three-part displaced fracture of the upper end of the humerus. You can see how badly displaced it is, and you know that it can be managed only by the operative interference with the plating. Next, please. And this is how what we did was using the similar kind of frame in this lady, and she could actually, in frames in situ, could start movement on the second or third day. And you can see an excellent radiological alignment, which you've seen even in the bad fracture displaced. Next, please. And this is how at the end of 12 weeks, we could get excellent union, and we have removed those K-wires, and she has gone back to her teaching dancing. Next, please. This is how after 12 weeks we could start movement, and in about 4 months she started mobilization easily. Next, please. This is another case of a three-part fracture which was unstable and osteoporotic again. We simply used 3 K wires on the top and 2 on the down, and getting those compressions, so getting a good compression with good stability. Next, please. And this is how this patient, in spite of telling him not to move his arm, he started movements laterally, and he actually started abduction and rotation with this frame on. We could see that the union was very good, and he gained practically all the range of motion. Next, please. This is again another unstable two-part fracture. This patient was post-operatively put K-wires like that, and this was the follow-up after 6 months. Next, please. And this was the follow-up of the same patient, because he in fact removed those K-wires on himself. He came with the other hand fracture or other forearm fracture. We realized the scars on the other hand. We realized that he had a fracture, so that's why we got a follow-up X-ray, and to our surprise that it was united well. But there are some problems. There could be a loss of reduction in some of the cases when patient is slightly adventurous and starts abducting his hand with the frame in situ. So these proximal K-wires can loosen, and it could also possibly give rise to some malunion cases. And this patient was lost to follow-up, and after 1 month. Next, please. But he came back after about 6 months, and he had practically 90% range of motion. And that is what we realized, that even in such cases we can manage. And it is also can handle some cases like this when it is a comminuted, badly fractured upper end of the humerus with middle humerus, which could also be operated. This particular case was an open fracture, so we had no option to do this external fixator, and we tried that, getting good results at the end. Next, please. And this is what in the ipsilateral multiple fractures, we can use it in the lower end of the upper end of the humerus plus lower end of the radius. Both these things could be managed at the same time with different frames. Next, please. So this is what a joystick technique that I was talking about. We could get a good close reduction. This is how we have used a simple K-wires, getting those reduction properly. You can see on the left, it is badly displaced, and the reduction is this whole humeral head is in varus. We have got that varus corrected with passing those 2 K-wires at a time and getting that reduction. Next, please. And that reduction also with joysticking can be done almost up to 2 to 3 weeks. But you have to put 2 to 3 K-wires to get a hold of upper end of the humerus. You can't do that with 1 K-wire. So this is an 85-year-old lady who also had a similar kind of fracture, which of course with such osteoporosis was very difficult to plate or do something. We use this similar kind of frame with little modification. Next, please. Sometimes we have to also span the joint, go to the acrobion and get a good hold. And let me tell you that it is excellent, especially in the osteoporotic cases. And contrary to the thought that osteoporotic cases, you will have loosening of the K-wires. But if you put the K-wires in different direction, it's less likely that they can come out or they will have a pull out. So we did about 72 cases till 2012. We've done more than about 200 cases by now, and with good follow-up and documentation. So age group of the cases operated were from 35 to 85 years. 60% of them were females. The next, please. And the advantages of this method, as you see, that it's a biological stabilization. We don't have to do very bad dissection, which are chances of fibrosis is there. Early mobilization can be started as early as second or third day. And the chances of edema and fibrosis of the capsule is very low. So we hardly have any stiffness at the end of 2 to 3 months when we get a good union. So subsequent reduction or re-reduction, in case if you think that the KOR are loosening, is easily possible. If you think that there is a virus happening, we can actually change those outside link screws and get the reduction again. Again, this removal of the KOR is done without any anesthesia. It's an OPD procedure. It could be done. Perhaps the most important is it's cost effective. It's very economical, and the whole construct cost about 2 to 2,500 rupees. And many of these parts like link joints, some KORs, etc., could be reused after autoclaving. It's a relatively simple technique, and relatively younger consultants can do this. And we have seen more than 1,000 cases being operated after our courses, and they have sent those cases to us, their post-operative results, etc. And we are very happy that this has been popularized in many tier 3 cities and the rural centers. And the compound fractures could be easily managed by external fixator, as all of us know. There are, of course, some disadvantages of pin tract infection or delayed union. As I told you, the pin tract infection can be minimized, though we cannot say 100% eliminated, by using a simple smooth K wires of 2 to 2.5 millimeter diameter and using a mechanical drill with a rotation of less than 300 RPM, which reduces the chances of heat generation, and chances of necrosis of the skin around is lessened. So we make a small incision with a number 11 knife and pass an artery or a hemostat, open it out and pass the drill after that. So that once there is no heat necrosis, the chance of infection is minimized. It's of course uncomfortable to the patient because it's an external device, and that's why patient has to be counseled before telling this, show them the model and tell them this is what we are going to put and take the permission. You will be surprised that many of the patients who are relatively educated opt for this because the scar is minimal. It's just a pin tract that we have this. So that's why they don't. And plus the second operation is not needed to remove the implant. And we can practically give a guarantee of this to almost 90% of the cases which have no. We have seen a couple of non-unions and malunions, but compared to what we would operate, and because we have seen such problems with even Philos plating, the titanium plate that we have, the latest AO gadgets, but we still see some problems with that if it is not used properly. Most of the time, the C-arm is needed in this, and that's one of the disadvantages, especially in the rural areas where we actually advocate these cases to be done by JESS. Next, please. So in conclusion, it's a very effective, minimally invasive method. Satisfactory fracture reduction can be done. The stability is very good. In fact, we want a relative stability which allows a little bit of fracture motion and which allows healthy healing at the end of it. The complication rates are very low, as we can see from the results. The good early functional results are very good, and it's relatively simple technique. Younger consultants can do, and it is extremely economical way of managing these fractures.
I will start the video. I have video in another.
Oh, you have a video. Okay, we can show those videos that will give them an idea of motion on the table and also C-arm videos. Please.
Just a second. Huh?
Yeah. Thank you, Rajesh, for helping me, supporting me as usual, and coming to my rescue. This is what I was telling, the friends should always help the friends.
Can you see the video now?
Yes, sir, it's on.
So this is the greater, I have shown the 4-part fracture in which the greater tuberosity, the lesser tuberosity, we can see the humeral head and the shaft. And this is how we are going to hold the lesser tuberosity with one wire, the greater tuberosity, keeping the arm abducted so that the greater tuberosity comes as close to the humeral head as possible. This is how we pass those K wires in a different direction and different planes so that it holds the greater tuberosity along with the humeral head. And this is how 2 to 3 K wires, sometimes even 4 K wires can be passed, and you'll be amazed by the stability. You have to take care that the biceps tendon is not impaired. And similarly, the concentric manner that we pass those K wires in the shaft so that we have a better hold of these K wires. This is of course shown on the model first, and this is the arc. By a railroading method, you can pass a link joint, and these are special link joints which are medium size, can get 3 by 3 millimeter by 3 millimeter connecting rod and the K wires through it. And then we pass it. Of course, it is easier to show you on the model. Slightly, we have to use our dexterity. And then you tighten with the 3.5 screwdriver, which is a universal this thing gauge that we have for all the grub screws. And then tighten those, holding the K wires together so that it holds the K wires very well. This is how it is seen, the upper end. Pass another arc so that we have extra stability. And then pass the similar connecting rod to the distal 2 K wires and hold these 2 K wires and the first proximal construct together with the connecting rod. We call that Y. The whole construct is called as a Y frame. And this is how we hold it. The reduction is checked under C-arm. And then tighten it with 3.5 millimeter screwdriver. And this is the basic procedure. This is
another one.
Rehabilitation which is started the second day when the pain is less. This lady is a senior citizen with osteoporotic bones. So do you have the on the table video, sir?
I'll just check it out. I have. Most likely I have. Am I seeing?
No.
Just a minute. Hold on, please.
Some technical glitch. It needs update.
Yeah, the codec is missing. I think this won't unless you take it online.
I think I'm not able to share it. Sorry for that.
Okay, do you have a C-arm video?
This was a C-arm video only, which I was sharing.
Okay, no problem. We just wanted to make you understand that the stability is checked. Stability is checked on the table, and we also see the C-arm video where all the movement, the flexion, extension, the abduction, also rotations are checked, and the stability is confirmed. And that is what. So thank you, Dr. Rajesh, for helping me out. So if there are any questions on this, I would welcome them.
You can stop share, yeah. And any
is
questions from Dr. Sara and Dr. Rajesh, and of course, any from the audience if they've come just now.
Yes, Dr. Sara.
Okay. I had the pleasure of meeting. Thank you very much for that very nice talk. I thought it was beautifully presented and very nice cases as well.
Thank you.
I had the pleasure of meeting Professor B.B. Joshi when he and Professor Venkataswamy both came together for our first hand surgery meeting in Malaysia. And that time he showed us a very ingenious fixator, but this was for the fingers. We did the workshop for the fingers. And that was very ingenious already, but this is something different. I think we were not exposed to this. And I noticed that it seems to be more low profile probably because the wires are curved and it like hugs the body. I wonder, do you have a lot of backing out of the wires?
No, no. Thank you for asking me this question, because lots of people ask this question. Because in the beginning, we used to use threaded K wires like a chance screws, those which were 2.5 millimeter. But we realized that it generates a lot of heat when we are passing that. Okay. And that heat causes a nidus for infection, which
Right.
can cause a pin loosening and infection, which were quite a lot in the beginning when we started using. And just in order to prevent this, we started using a smooth K wires with a low intensity drill, so that the RPM of this drill is again very low, less than 300 RPM, which doesn't generate much heat. Okay. We also used hand drills also to use that. As you know, some of the Elizarov surgeons still use that in order to reduce the chances of heat generation. Okay. And that actually helped. Another thing is that chances of this pull out we are reducing by passing those K wires in different directions.
Right.
And tightening those K wires. So we
Pre-stressing.
instead of tensioning, we call that tightening with a link joint. Okay. And that, of course, Dr. Rajesh also with me, we are in the same team of the faculty which teaches across. And this is the most commonly asked question about pull out of this K wire. And we hardly ever, I would say hardly ever see any pull out or loosening of this K wire when we pass this with a link joint. Of course, there are chances of these grub screws loosening. That's why we have standardized these link joints, having a grub screw which is tightened. Unless patient is little naughty and mischievous, I don't think and I don't see any K wires. And in fact, we use that in the weight bearing joints like in tibia, ankle, even upper end of the tibia, and we have different frames designed, and we have more or less standardized these frames. And we have, you will be surprised that we have now operated besides CTV, which you also probably will be knowing, JESS fixators for intractable or neuropathic feet, or those which have been recurrent, those have been operated, and arthrogyphotic, etc. Those cases we have been managing that, and more than 10,000 such cases have been operated throughout India. And for this JESS, for the periarticular region and intra-articular fractures, especially of the lower end of the radius, lower end of the humerus, upper end of the humerus, upper end of the tibia, the pylon fractures lower. I think this has proved to be excellent method of managing these cases. And again, I would not know exact number, but those are also in thousands that have been done. And we have been more than satisfied with results.
Thank you. So apart from the C-arm, it's all quite cost effective. Congratulations. Sorry,
Thank you.
please carry on.
So it is like less than $10.
Well done.
In fact, we had one innovative award also for this, and because the utility and the cost-effective thing, which is very important for the third world countries and developing countries, and that's the reason why it is very popular. But it is very important to do this and to learn this properly by reading books or to see workshops, doing it properly under some guidance before you actually embark. Because there are, of course, lots of complications which can occur like any other system if you do not handle it properly.
Right.
Yes, Dr. Madam?
Yeah, unfortunately, Dr. Gandhi was not able to show us the C-arm slides. How do you place the tube? Because getting axial views for the shoulder intraoperative, to my mind, is very difficult.
Yeah, it is.
But we have not been able.
Okay, so you have to put the neck. See, most of these cases we do under regional anesthesia, interscalene. Okay, so it is possible to actually instruct the patient, or if the patient is under general anesthesia, the neck has to be on the other side. Okay,
Yeah.
supposing the left shoulder is being operated, you have to put the neck on the other side, and you have to get the patient on the edge of the table laterally. Okay, abduct the hand and put the C-arm, the view, this thing on the axilla. Just like how you take the X-ray of the axilla and shoot through, keeping the head on the other side. It is little bit of acrobatics, but it can be done. Okay, because that has to be done, because if you don't have a lateral X-ray of the axillary vein, you cannot be sure, because just like a femur, the subtrochanteric fracture, etc., when you see the lateral, the distal part sags down. Okay, because the gravity, it sags down, and that needs to be actually pushed up. And this is the same case in the upper limb also. So that is very important. It is very vital to get good reduction. But it can be done. It is not impossible. It is little bit of jugglery in the beginning, but you can do it. In fact, this is what I had shown you in that C-arm, but unfortunately video couldn't be shown.
It has some codec problem. Somehow it didn't work out this time.
Share all this, that itself is good enough. Yes. Any more questions, Dr. Chasanal?
No, sir. Patni ma'am wanted to ask something.
No, I've already had my.
Okay.
So I think we can wind up then, because I think we are half an hour past the scheduled time.
Oh, yeah.
But I think we've had a very engaged audience, because YouTube and Facebook both are live. So I'm very happy to see that. And the most important thing I've seen in both these presentations, I think, is that it's the body of work which both the speakers have shown has been focused on keeping it simple for the patient. Having a method that is cost effective, having a method that's durable, and done with the least kind of morbidity to the upper limb. And I think the message for that is that if there's a good learning curve and reasonable experience, I think both these methods can work very, very well in every orthopedic surgeon's hand. So I'm sure our audience is going to find both these talks very useful, and with all the reruns. And
can I add?
Yeah, sure.
In fact, our challenge and the obstacle is that we have a very low learning curve. And that's why people tend to be overconfident. And that's when the problems start. Because as you know, we have a very, very peculiar habit in Indian surgeons, that the first case that they do, they try to modify the basic things. Okay, so that should never be done, because these methods or these structures or the frames which have come, we have gone through the whole process and tried different frames, and we have seen that many other frames have failed. So we have come to some kind of standardized frame. And then if somebody goes and does the first 5 cases, starts modifying that, he will go through the same cycle that we have gone through. So we always tell them that you first read about it, you see somebody doing it, and then actually you can start doing it on the patient. But unfortunately here, some of the surgeons start straight away on the patients, and then they can really land up like problems like Abhimanyu, where they know how to go in, but they don't know how to come out. And that's the problem, So they should not get overconfident, because this looks very simple. It's innovative, but it has some challenges.
And before we wind up and Chasanal does a vote of thanks, I would like to request Dr. Sara and Patni Madam to both give us a message for the future, especially for voice.
Not boys, voice.
Okay, congratulations and thank you very much for inviting us. And I think I have to say happy birthday to Dr. MullaFeroze. And I really admire the legacy that she has left and the way that all of you are handling it and moving forward very fast. So I'm very proud to be here at this inaugural talk, and congratulations and all the best for the future.
Thank you, ma'am. Thank you. And Patni ma'am, any words of advice really?
No. Who am I to advise? But yes, it has been an excellent evening. And I wouldn't say advice, but, to the fellow women orthopedicians is that your work should speak for you. You are your own ambassador. And I hope to see a time where we don't need a separate Women's Orthopedic Association to be seen.
Absolutely, absolutely.
I don't know.
We will keep that in mind, and next year's thrust in IOA will be inclusiveness everywhere.
Yes.
Yes, it has already started. I don't think you all need any separate organization for being recognized. So all are recognized. It is just that
we want to proliferate and seep into every osteoblast.
Oh, yeah,
Yes.
definitely.
Exactly.
That's a welcome
the
thing.
Bastion is scared.
Yes, yes, yes.
And you don't want to be seen, oh, there's an osteoblast. No.
Okay.
Yeah,
Okay, great.
That is my advice.
Thank you, ma'am. Thank you. Chasanal, will you please do the vote of thanks?
Yeah, so on behalf of W.O.I.C.E, I thank our respected chairpersons, Sara ma'am and Rajesh Gandhi sir for chairing this session and joining us for this first episode. And special thanks to our speakers, Patni ma'am, who has spared time all the way from Netherlands while she was not even here in India. And Ram Prabhoo sir, of course, thank you, sir, for all the guidance, support, and being part of the first episode with us here. And it was a wonderful and a worthwhile Sunday evening with all of you. We are thankful to Indian Ortho Association and IOA TV, Asia Pacific Ortho Association, the APOA Waves, and WOW, that is the Women Orthopedics Worldwide. And of course, the biggest thank you we have to say to Dr. Ashok Sham for this idea, for this platform, especially the OrthoTV Online Global, and for helping us through this entire webinar. And next week, that is on 10th, we'll be having the second episode, and we have Dr. Rujuta Kulkarni, who will be talking about limb lengthening, a journey, and Dr. Jamal Ashraf on periprosthetic fractures. And that's going to be the second episode for the Worthy series. And I hope to have all of you who are present here today to also attend the second episode of Worthy webinars. Thank you, everyone.
Thank you.
And have a wonderful evening.
Thank you very much.
Bye-bye.
Thank you.